welcome to the continuing education module on implicit bias. This is a module known as the explicit impact of implicit behaviors. My name is Lalita Prasad-Reddy, and I am the Assistant Dean for Pre-Clerkship Education at Chicago Medical School and a clinical pharmacy specialist at Rush University Internist, part of Rush University Medical Center. And I have a really big passion in diversity, equity, inclusion, and accessibility initiatives. So I'm very pleased to be giving this CE today on the dangers of implicit bias and how we as pharmacists can recognize our own implicit biases, microaggressions, and potential behaviors that may cause and increase inequities and in order to better serve our patients. So the learning objectives of this session today are to discuss avenues that lead to inequities in care, including implicit bias, microaggressions, and traditional race-based practices, describe the different levels of racism that exist in society with a focus on implicit preferences, and then finally, examine reasons for inequities in healthcare given a patient case. So whenever we do topics that may be sensitive or focused on diversity, equity, inclusion, accessibility, and justice issues, it's really important to just set the tone and establish some ground rules. So recognizing that we need to adopt a mindset that can work through discomfort and view mistakes as learning opportunities. So much of the content that is going to be present today could be potentially triggering and bothersome. And really, that should happen, and you should view this as unjustified, because only when we recognize that and we feel uncomfortable are we going to impart actual change. Understand the binary mindset. So we as humans often think of individuals are good or bad, individuals are racist or non-racist. But what it's really important to recognize is that good people make bad decisions, and people that we think of as bad people can also make good decisions. And so it's important to recognize that it's possible to act with good intentions and still perpetuate biases. Focus on impact, not intent. So oftentimes, many of us don't really have an intention to cause malicious intent or malicious harm, but we really need to see how our behaviors and our communications can be affected on the other side. So how did we affect somebody? Start with yourself, set aside time for reflection and feedback. So recognizing that everybody is on a spectrum and a different area in their journey towards diversity, equity, and inclusion. And it is really important to set aside time for feedback and reflection. Allow yourself and others to learn and be patient, recognizing that these types of change take a long time and that these changes are not going to be made overnight. But by starting with ourselves and allowing ourselves and others to learn, we will eventually impart a large magnitude of change. Identify barriers and blocks both within ourselves, within our institutions, and systemically that may prevent progression in this area, and propose manageable goals. Stay in this discomfort and call attention to stereotypes, to racism, to prejudices, and learn how it operates. So it's really important to recognize that there are several different types of disparities that exist in healthcare, and there are many types of reasons that these disparities in healthcare exist. So what you see on this slide right here are known as the social determinants of health, and these are the conditions that we live, we work, and that we learn in. And essentially access to different social determinants are essentially what is going to dictate what our likelihood is of developing a disease, or if we do develop a chronic condition, how well it will be managed. So more and more evidence is coming out that suggests that it is not genetics and ancestry that play the larger role in depicting what predicts future health status, but instead maybe 80% of our health status can be predicted by the social determinants of health. So you can see that there's a large variety of determinants that are going to give rise to how well and how proper of a health status somebody can have. We will talk about this a little bit more when we talk about the depth gap later on in this session, but something that I do want to call attention to is when we think about social determinants, we all often think about access to healthcare, education and health literacy level, socioeconomic status, housing status, what is somebody's familial support, what is their transportation status, but really what is also considered a social determinant of health is discrimination. So if somebody has felt discriminated or stigmatized in the healthcare encounter, then that is going to have potential implications on their health status. So there are several examples of healthcare disparities that exist. And I think that it's important for me to also preface this by saying that in my attempt to provide this CE, we cannot completely be inclusive of all populations or all disparities that exist. And so I've picked out some pertinent ones and some more profound ones, but that doesn't mean that disparities don't exist or other things don't exist in other populations and circles. So what is important to recognize here is healthcare disparities have a higher prevalence in populations that have been historically marginalized. So when we think about populations that are historically marginalized, it would be your racial and ethnic minorities, individuals who identify as LGBTQIA+, individuals living with a disability, individuals who have a lower socioeconomic status, individuals who are immigrants from other country, older adults as well as children. So essentially any population that has been historically marginalized is going to have a higher risk of developing healthcare inequities. This really came to light and we were forced to reckon with it with COVID-19. So we knew that in COVID, individuals who identified as Black had a much higher prevalence of chronic diseases such as heart failure, diabetes, and hypertension. But they also carried a much more disproportionate percentage and prevalence of COVID-19. Even when that prevalence was increased with COVID-19, when you mark and account for those factors, there is still less quality of care, less supportive care, less access to hospitalizations. Now, these are patterns that we see in many other populations. So you can see on this slide on the left, individuals who identify as LGBTQIA face health disparities that are linked to stigma and discrimination. They're more likely to attempt suicide. They're more likely to be diagnosed with a mental health condition and then not treated effectively for that mental health condition. Individuals who are living with a disability in this middle slide are more likely to have a chronic condition. And so you can see here that there is a larger prevalence of chronic conditions and disease in individuals who are historically marginalized and historically underrepresented. Now, what is really important is to recognize what is causing that increased prevalence. So systemic racism in healthcare really stems out of multiple things. So we do know that implicit bias and microaggressions exist, and that there are implicit preferences to individuals that are historically more privileged versus individuals that come from historically marginalized community. We do know that there's a decreased number of minority professionals in the healthcare field. So if we just take two large ethnic populations and racial populations are individuals who identify as Black or individuals who identify as Latino, well, then that makes up almost 30% of the United States population. But then why is it only that they make up 13% of our healthcare professionals? So you can see that there's certainly a disparity towards the number of the pipelining of underrepresented populations into professional healthcare roles. There are multiple automatic practices built in calculators and built in our everyday healthcare practice that actually give rise to inequities. And this is known as the practice of race-based medicine. And then certainly the social determinants of health. So it's not just somebody's access to care, access to housing, access to transportation, but it is also, have they been discriminated and stigmatized in the healthcare encounter? Because we do know that there are consequences of that in terms of their foregoing healthcare status. So implicit bias is one of the ways that we as ourselves can work on our own biases to better our communities and better ourselves. So bias is a prejudice in favor of or against one thing, person, or group compared with another, usually in a way that's considered to be unfair. These biases can be held by an individual, group, or institution, and they have negative or positive consequences, definitely far more likely to have negative consequences that affect another group. The truth of the matter is implicit bias, and having an implicit bias doesn't make you bad. It just makes you human. We all have implicit biases. We just need to be able to dismantle them. We need to be able to recognize them and use the tools in our kit to be able to approach them and ensure that they don't affect our clinical decision making. These are the results of our cultural conditioning, the way that we have learned, our family life, and our behaviors and prejudices that have been passed down. They are often contrary to our personal values, where we explicitly say, no, I don't believe that way, but implicitly we do have biases that really operate on a more subconscious level. So it is important to recognize where implicit bias lives in the levels of racism. So as I had mentioned, implicit bias is really interpersonal in nature. So I would hope that anybody who is a healthcare professional is going into healthcare because they have an altruistic mission to serve others. And we would hope that we can all agree that there is no place for explicit prejudice, explicit racism, explicit stereotyping among healthcare providers or among society. Nonetheless, it does exist. However, we do know that interpersonal and implicit biases are prevalent in anybody. So when we think about internalized racism, this is racism that exists within marginalized communities. These are internalized feelings that marginalized and underrepresented communities start to believe about themselves because of the way they have been treated, the way that they have been marginalized. So they start to internalize and basically threaten themselves with those stereotypes. They start to think, well, if people keep saying this is true, perhaps it is true. Implicit bias operates on the level of interpersonal racism. So these are the communication styles. These are the prejudices that affect our interpersonal communication from one person to another. Institutionalized racism would be racism that exists within our institutions, within our educational systems, within our prison systems, within our healthcare systems. And so we certainly know that institutional racism exists. So this can be thought back to when there was educational learning segregation between racial minorities and individuals who identified as white. We can think about institutionalized racism that exists in the healthcare system. So again, most of us go into healthcare because we are altruistic and we have a benevolent desire to serve other individuals. But the healthcare institution has often and long been considered one of potentially the most racist institutions in America. Think of just the way insurance operates. Basically, your socioeconomic status is going to depict what level of care you get. And then structural systemic racism is racism that is woven into our policies and our history. So this is very, very systemic in nature. So, this is the depth gap that exists because of redlining, where individuals and housing policies, the lack of ethnic and racial minorities being able to get housing loans, so then they were segregated to other areas. These are systemic policies that continue to reinforce and perpetuate perpetuate behaviors where we provide resources to one population that is more underrepresented, and we keep resources and power within populations that are historically more privileged. So, true or false, the following scenario would be considered an implicit, not an explicit bias. So, a family practice practitioner has a clinic which sees patients of all ages. Maya, an 86-year-old female, states that in the past few months she feels lonely, has less energy, and feels apathetic. She complains of anhedonia and decreased appetite. The pharmacy resident asked the physician about the potential of treating Maya's depressive symptoms, and the physician responds, "It's a normal part of aging. I see it with everyone." So is this true or false? Well, we certainly know that there is probably a greater likelihood of depression and isolation as individuals get older, but to essentially say that this is normal, this is a part of aging, and it's prevalent with anybody is going to be a bias coming through. So where do biases begin? So as we had mentioned, these are really parts of our cultural experiences and our conditioning. So what are our cultural behaviors? What are the religions? What are the values and the norms that we live by? And how have those framed some of our thoughts and experiences? What is the purpose of what type of societal experiences we have? So what have we been told from the news? What have we been told from the beginning from our textbooks? So those are going to ultimately start those are going to assist in our development of biases internally. What are our past experiences? So we have a tendency to essentially generalize that one past experience with somebody is going to be generalized to whatever that is to the larger population. And that does happen. We do know that if there's individuals that have experiences with certain populations, that they tend to generalize those to that entire population. Perhaps it was one encounter that wasn't pleasant, and now it is generalized to the larger population. And then our environmental exposure. So just like the social determinants are the conditions and the cases where we learn, live, and work, and the conditions and how we learn, live, and work, our biases are also formed by the way we learn, live, and work. So which of these plays a role in the formation of implicit bias? Is it past encounters and experiences, the practice of mindfulness, family upbringing, or ANC? So as I had mentioned, it's really our past encounters and experiences and our societal experiences and cultural conditioning that really play a role in the formation and development of implicit biases. Practicing mindfulness can be one of the tools that we utilize to actually reduce and mitigate the effects of implicit biases on our behaviors. There are several types of biases. There's actually been more than, I think, 500 types of biases identified. But here I am going to just kind of bring out some of those that are more prevalent in our society. So affinity bias. Affinity bias, we all know we tend to acclimate and we tend to be drawn to individuals who we consider are like-minded. And so this is affinity bias playing. Affinity bias essentially says, I am going to have a preference and an implicit preference for individuals who think like I do. Beauty bias. So we certainly know in Western society and really everywhere in the world that individuals who are considered beautiful or attractive are given this extra layer of privilege. So there have been several studies that have been done that really look at the effects of somebody who is attractive and what that does to somebody's implicit preferences. And study after study has demonstrated that the majority of individuals in our society are going to have a preference for individuals who are considered to be more attractive or more beautiful. We tend to think that they are more capable. We tend to think that they have a higher level of status in our society. Gender bias. Gender bias plays a significant role in our workplace. So we know that there still continues to be this disparity in terms of income and in terms of income disparities from individuals who are male versus individuals who are female. This is gender bias at play, where for whatever reason, even if the male and the female are playing the exact same role and fulfilling the exact same professional expectation, that male is more likely to be compensated at a higher level. Halo bias would be you're going to tend to have a preference for individuals who you see as good in nature and agreeing with you, versus Horn's bias is going to be a displeasure with individuals who have differing preferences than you. So if you think that, oh, that person's going to disagree with me, then I'm just going to kind of avoid. That would be the Horn bias coming into play. We do know that there are several factors that are prone to exposure to bias. And so you are more likely to have bias towards you by another individual if you are on either age spectrum. So if you're a child or if you're an older adult, we do know that ageism is alive and a really big problem. Body habituous. So we do know that there is prevalent bias in our society among individuals who are considered overweight or obese. Individuals who are a racial or ethnic minority. This idea of ableism, where an individual who is living without a disability is thought to be more capable than an individual living with a disability. So this idea of ableism. Economic status, we do know that individuals of lower socioeconomic status are going to be more prone to having bias against them. Individuals who are not gender conforming, individuals that have an immigration status, people living with a mental health condition, if you are a different nationality, race, or ethnicity, if you are not if you're not considered Anglo-Saxon and following what is considered to be Christianity, if you're practicing another religion, it's thought that you're supposed to be at a higher risk of bias. If you have substance abuse history, or if you are somebody that identifies as LGBTQIA+. So again, just underlying the fact that individuals that are coming from populations that are historically marginalized, historically underrepresented, not thought to be the privileged population, are now again going to be prone to bias. So implicit bias is categorizing people without realizing it. It's as natural as breathing and allows us to navigate the world. So again, implicit bias doesn't make you bad. It makes you human. It's automatic and operates at an unconscious level, which is often in contrast and in conflict with our conscious experiences and our conscious thought processes. It's ingrained and is reflexive, and starts occurring at a young age because of repeated reinforcements of stereotypes. So we think about imprinting, we think about what we say to our children, because we know if our children hear the same thing over and over and over, they're more likely to start to begin to think that's true. And so being really cognizant about how we are communicating and being really cognizant of how we are portraying stereotypes and prejudices is very, very important. And here's an example of implicit bias in play. So I want to just take a second and I want you to think about, when you hear the word strong, charismatic leader, what comes to mind? And then when you hear the word a caring, compassionate, and sincere worker, what comes to mind? The purpose of this activity is to get us to understand how ingrained our biases is. So regardless of who came to your mind when you heard the word strong, charismatic leader or caring, compassionate, and sincere worker, perhaps you had thought about someone that you work with. Perhaps you had an ambiguous idea in your mind. Whatever it is this study has been done on several different levels, and over 80% of the population, when they say they hear the word strong, charismatic leader, associate this with a male. And when you hear the words a caring, compassionate, and sincere worker, we associate that with the description of a female. And so the question is, why can't a strong, charismatic leader, why can't the first thing that come to mind be a female or a woman? When we think about a caring, compassionate, and sincere worker, why is it more likely that we see a woman in our mind and not a male? So those are our implicit biases coming to play, where we associate these words and these thoughts with a certain type of person. So how does implicit bias operate on a healthcare level? Well, what types of implicit biases have you observed or experienced in healthcare? Have you experienced the tailor of medication therapy based on the race of a patient? The lack of access opportunities to specialty providers based on patient socioeconomic status? A patient request to see a different practitioner based on gender or age? More than one, or none of the above? So these are all examples of potential implicit biases that have occurred in healthcare. As I had mentioned, most of us go into healthcare because we want to serve other individuals, and we have a true desire to do that. Most of healthcare professionals would not justify or would not admit to any explicit preferences for individual people. However, implicit preferences for individuals are very, very prevalent among healthcare professionals. And these are just a few of the studies that demonstrate that. So when we look at implicit bias among healthcare professionals, the first study assessed implicit and explicit bias among individuals who identified as Hispanic or Latino and Black Americans among primary care providers. And interestingly, is the healthcare professionals said, no, I have no explicit preference towards ethnic minorities versus individuals who identify as white. There is no explicit preference. I would treat everybody the same. But when they did the implicit association test, physicians showed a moderate pro-white anti-Black bias, and they showed a moderate pro-white anti-Hispanic Latina bias. The second study looked at the level of anti-fat bias that was prevalent in healthcare professionals. Now, what is interesting here is these are healthcare professionals that actually work in obesity clinics. And these are healthcare professionals that are trained to work with individuals that are overweight and obese. And what they found was those healthcare professionals that specialized in obesity and obesity medicine exhibited a significant pro-thin anti-fat bias. The third study looked at implicit and explicit attitudes towards individuals who identified as lesbian or gay. And in that study, they found that among individuals that identified as heterosexual, implicit preferences always favored heterosexual people. Implicit preferences for heterosexual women were weaker than implicit preference for heterosexual men. And explicit preferences for heterosexual individuals versus individuals who identified as lesbian or gay were weaker than explicit preferences. Again, showing that explicitly, individuals didn't recognize that they had implicit preferences. And the final study looked at providers' attitudes towards individuals living with a disability. And explicit attitudes indicated very little prejudice, but their implicit attitudes revealed that they preferred individuals who are not living with a disability. So again, they were practicing ableism. These preferences start from we know from early on, and these preferences and these prejudices and stereotypes get reinforced in education. So these studies looked at populations who were completing healthcare education. So in pharmacy students who were first year, they revealed that the majority of participants displayed implicit biases towards Caucasians. In a multidisciplinary study that included medical pharmacy and training and nursing trainees, cultural biases were recognized that suggested that individuals who were light skinned were preferred to individuals who were dark skinned. In a study that assessed first year medical students and assessed for implicit bias towards individuals who identified as lesbian or gay, almost half of those respondents expressed explicit bias and 80% explicit implicit bias. So you can see again that it is very, very prevalent. So even if explicitly it doesn't match with the implicit preferences, you can see that the implicit bias is affecting how we think. Why does it matter if we have biases? Well, providers and healthcare professionals who exhibit biases are more likely to be less supportive of patients. If you exhibit bias, you're more likely to be dismissive of your patients, spend less time with your patients, not have a thorough focus on clinical decision making, have a higher risk of burnout, lack empathy, exhibit unhealthy communication. You are less likely to refer patients to specialty care and provide overall quality of care. When an individual feels stigmatized and has been discriminated on from the patient side, this has overarching consequences as well. We know that if discrimination, bias, and prejudice is felt from the patient side, there's obviously going to be less patient satisfaction. There's going to be less confidence in that healthcare provider. You're not going to be likely to follow through with that healthcare provider's recommendations. There's more distrust in the healthcare system. And this is how distrust continues to be reinforced and perpetuated. There's less confidence, lack of follow-up, again, because you're not believing that that individual had their right intention. They didn't display empathy. They didn't display that they were truly engaged in your well-being. There is postponing access to care, and again, affects overall quality of care with a higher morbidity and higher mortality. Some of the more tangible effects of bias that have been cited in the literature is, the way that we care for individuals. So one of these long-standing hypotheses and thoughts is that individuals who are Black have less sensitive nerve endings to individuals who are white. So this thought, even though it is not scientifically based or proven, has really perpetuated healthcare communities. And ultimately, the outcome that is affected is that research has shown that Black patients are undertreated for pain. We do know that patients of color and patients of ethnic and racial minorities are more likely to be blamed for being passive in their healthcare and not taking ownership. We do know that individuals who identify as Hispanic or Latino are less likely to receive pain medications, and when they are prescribed, they prescribe them at lower doses. We know that individuals who are Black are less likely to receive evidence-based care for heart failure, stroke, post-MI. We know that physicians are less likely to treat depression, mental health, and suicidal ideation in elderly patients. Again, going back to that slide where it's often just thought of this is a normal part of aging. Women are 3 times less likely to be referred for total knee replacement. And ultimately, these are effects of bias and systemic racism that really negatively impact patient care. So Now that we know the dangers of bias, how can we check our biases? Well, there's different ways. The implicit association test is a test that is born out of Harvard, and it is commonly used and considered by many to be the most effective tool for measuring implicit bias. So the way that this test works is an examinee is shown the list of words and pictures that will be used in the test, and then they're basically told to divide and relay that word, match that word or picture to a group of contrasting concepts. So really thinking back to perhaps if you had a male or a woman as your two pictures and your description was strong, charismatic leader, you would be more likely, or the majority of the population would be more likely to match that characteristic with that man. So that is how this test works. And the principle behind the IAT is that responses are going to occur quickly if the examinee has an underlying belief that those words are more associated with one concept over another. Upon completion of the test, the examinee is then provided with the results. Now, if you do decide to pursue the implicit association test, it is really important that education is provided, because it can be very uncomfortable when individuals are given those results of the study, because they often, as I had mentioned, are in conflict with explicit preferences. So you do need an individual that is trained to help people and analyze and navigate through these implicit beliefs. Now, the IAT may divulge info about bias, but it doesn't examine behaviors. With that, it is important that when those individuals are given those results, there may be cognitive dissonance. And that cognitive dissonance is going to be that uncomfortable state when individuals are aware of an inconsistency in their beliefs, attitudes, or behaviors. And that is when change comes. So growth does not come without discomfort. But again, you do need somebody that is well-trained and can navigate that appropriately. So going back, other examples of how implicit bias affects healthcare are just listed here. Unfortunately, the examples are endless. There are so many examples of how implicit bias affects healthcare. Implicit bias can also affect realms and spheres outside of healthcare. So we've talked about how it affects quality, but we do know that admissions processes, promotion and hiring, growth opportunities, and recruitment opportunities are plagued by bias. And these are one of the reasons why underrepresented populations continue not to be pipelined into healthcare professions the same way that more privileged populations are. So there are recommendations that if you are on an admissions committee, if you are on search committees, that implicit bias training may assist in ensuring that you are recruiting and you are selecting individuals that have more diverse fields. So the University of Minnesota a few years ago actually required admissions implicit bias training for anybody that served on the School of Pharmacy admissions committee. And the following year, they actually recruited the most diverse class ever. So it worked, right? So they were able to ensure and check their own implicit biases. We have to be aware of the pervasiveness of implicit bias among the healthcare system. So we cannot negate or deny that racism, bias, stereotype, prejudice exists in our society and penetrates healthcare. And so by being aware of this and recognizing the degree that it perpetuates behaviors and among all levels of racism will help us ensure that it doesn't affect the way that we impact patient care. We need to understand the purpose of these self-assessments, how to use them, how to interpret findings, how implicit bias affects patients, and how to apply techniques for mitigating the effects. And being aware with using control strategies is going to ultimately reduce the presence of bias. thinking about if we know now from the IIT what are our prejudice and stereotypes that and our behaviors, we can use different tools to make sure that we catch ourselves. So introspection, understanding why we might have that bias. What kinds of cultural conditioning or experiences have we had that are making us think that way? Practicing mindfulness, being in the moment, not being dismissive, being thorough, and being present, perspective taking, understanding and trying to empathize with the individual on the other side. Learning to slow down. So we do know that healthcare is a fast-paced environment in clinical practice and retail practice. We are often just doing the grind. So trying to learn to slow down and think about what we are doing. Individuation is similar to perspective taking, checking your messaging and your communication, trying to operationalize and institutionalize this concept of fairness and equity. And take two. I am sorry I said that. I am sorry I thought that way. Let me try again. And with this, we will be able to better address those interpersonal spheres of implicit bias that exist in that interpersonal racist level. Now, with a few minutes left, I did want to talk about how implicit biases can actually penetrate higher levels of racism, structural and systemic. So structural racism is a system in which public policies, practices, norms work in reinforcing ways to perpetuate racial group inequities. It identifies dimensions of our history and culture that have allowed privilege to remain in certain populations and disadvantaged and reallocation of resource to remain with those that needed power. So really recognizing what this is saying is our privilege and recognizing that individuals may have privilege in different ways. So perhaps somebody is an individual who is an ethnic minority, but comes from a higher socioeconomic class. Well, perhaps then they've had some discrimination and stigmatization from being a racial or ethnic minority, but there is a certain amount of privilege that comes from being in a higher socioeconomic class. In contrast, there may be somebody who identifies as a privileged racial population, but comes from a lower socioeconomic class. So those ways and those characteristics that work together to give ourselves our own life experiences, that is this concept of intersectionality. And really, this is just understanding our own privilege and how we can use our own privilege to help advocate for individuals who may not be as privileged. So how can we work towards inclusion? Well, we ultimately need to make an overall cultural shift, but that is slow. So it starts within ourselves. Think about it, especially if you are on a recruitment team, on an admissions team, or you are just working with patients. Implicit bias training can be functional and actionable. Think about how we can pipeline more marginalized and underrepresented groups into healthcare. Think about how we can pipeline more marginalized groups into promotion and recruitment opportunities. Faculty and staff training, seminars longitudinally to continually reinforce DEIA perspectives. Consider going gender neutral. The fact that we do live in a binary society and we think of individuals as male or female, that can be biased towards individuals who are not gender conforming. And it is that is a way that we can respect individuals who are not gender conforming. Make sure that if you're on the educational side or you're a preceptor, provide teaching materials in a diversity of formats. So making sure that if you give PowerPoint slides, perhaps you can provide charts or written notes for individuals who learn in those ways. Perhaps you can record lectures. So if you're an individual that has more challenge in reading, you can listen to the lectures. Examples are if you're teaching dermatologic conditions, making sure that you're using pictures of individuals of all skin colors, because we do know things like psoriasis present in different ways in a lighter skinned individual versus somebody who is darker skin. Consider the application processes that you utilize. Do you require individuals to come on site? Is that biased towards individuals that may not have the resources financially to do that? How do you use standardized testing? Do you weight highly on standardized testing? Because we do know that standardized testing is going to marginalize vulnerable populations. Address underrepresentation of underrepresented populations in formal teaching materials. Celebrate diversity of individuals' holidays and celebrations. You may not be able to give a day off for every single international celebration, but send an email saying Happy New Year, Happy New Lunar New Year, Happy Hanukkah, Merry Christmas, Happy Diwali, and Happy Eid, so that you are celebrating the diversity that exists in our community. Promote the delivery of inclusive cases. Consider removing race from the history of present illness, because race is a social construct. It's going to tell us if there is a higher risk of individuals having less access to care, but biologically it has little meaning, and ultimately be an advocate that is continually learning. So here are some interventions and associated activities that can be utilized to help in mitigating implicit bias. So which of the following best describes an example of systemic racism in which one can challenge to improve healthcare inequity? Challenge our own self to assess and reflect on own implicit biases. This is where we start. Ignore social determinants and structural vulnerabilities in patients that may predispose to disease. We would never want to ignore the social determinants and structural vulnerabilities. Utilize race-based algorithms and calculators to guide treatment. This is another reason that biases exist, and you want to be careful when you use race-based algorithms. And practice stereotyping as a strategy to reduce implicit bias. You want to practice anti-stereotyping, so breaking stereotypes. And always remember the oath of the pharmacist. So I like to bring this to everybody's awareness, because the oath of a pharmacist was actually updated by the American Pharmacists Association to include promoting inclusion, embracing diversity, and advocating for justice to advance health equity. So this is a responsibility for us all. So I thank you for your time, and I hope you have found this session informative and useful.